But next up on the agenda, we're going to have our first speaker. And in this next section, we're going to hear from Dave Cottam, Chair of GDPC. And Dave leads the team at the head of the GDPC executive and is in regular and direct contact with the decision makers at high levels at the top of the NHS and the Department of Health, amongst others. And he represents GDPs, and one of the principal functions of this conference is for us frontline dentists to keep Dave informed about what goes on in practice. Now, if you have any questions for Dave, please write them in the chat and we'll do our best to get Dave to answer them. But if he's not able to answer you directly, he's very kindly agreed to respond to you in the chat during the day. So the Q&A function for GDPC will go ahead one way or another here. So Dave is now going to give us the latest on what he's been doing on our behalf. So over to you, Dave.
Okay, thanks very much indeed. And thank you, Leah, for inviting us, and good luck with the rest of the conference. Interesting times indeed. So as everybody knows, in these trying times, we've been having regular updates, regular letters of preparedness from the OCDO and the NHS England offices. There was huge delay and very poor communication to start with in this procedure that has improved with time. All manner of standing operating procedures have been produced, both from the CDO offices, the excellent ones from FGDP, Denplan, and indeed SDCEP, which has been referred to on many occasions, and the extremely good BDA toolkit, which has been updated. One of the other big problems we seem to be having in times is the reliance on PHE, Public Health England. It has tended and still continues to be in conflict with some of the other countries' guidances, but Public Health England does have primacy over what kit we wear and over our fallow time, which I'll come into a bit more. We've been asked and continue, it's mandatory now to fill in these workforce data forms, unduly complicated, often difficult to work out what is meant by working time equivalents for all team members, and many forms have had to be resubmitted. Of course, the real reason for this is so that the NHS counter fraud team can check that you are doing what it says on the tin, and that's continue to pay your staff and not make them redundant. Triaging is a big thing and continues to be so. There's been over 1.6 million triages done up to the 17th of July. Interestingly, courses of treatment compared this year with last year is only running at 13%. But these are the June figures, so it doesn't surprise me that it's well down on what one would expect from previous years. Communications have greatly improved with the CDO, and I take my hat off to, we've been ahead of getting ahead of these curve meetings. There's been 7 in number. We've got another 3 planned, been either every week or every other week. Twice weekly meetings with NHS England and the OCDO's offices to discuss contractual and operating issues, and numerous other meetings both with other countries and with the BDA Direct. I would at this point really just like to thank everybody that's been involved with these negotiations. Particular thanks go to the Vice Chairs, Sean and VJ, who've been unerring and giving up their time, to the exec, the odd meetings we've had, and indeed the GDPC for I think the 4 meetings we've had. But particular thanks has to go also to the BDA staff, to Penny and everybody involved, and last but not least to Martin Woodrow, who's been an absolute rock, involved in everything, blogs, webinars, advice, always available at the end of the phone. Martin, thank you very much, and continued negotiations are obviously carrying on. It's not been the same, unfortunately, in the other 3 countries. They're having immense difficulties, as we all are. In Wales, they're currently in the amber phase. Non-AGPs and UDCs are being used via the local pathways. They still have an abatement of 10%, although they're expected to pay their associates 100%. There are no UDA targets for 2021, provided you comply with the ACORN assessments And indeed, there's still an urge that they want you to see 5% more patients. In Scotland, again, they went into phase 3 from the 13th of July. Not perhaps going into full involvement till maybe mid to the end of August. Again, huge financial problems, and the UDCs there are being overrun in many cases. And they're all waiting on the latest SD set guidance. In Ireland, it's appalling. They, on the 20th, last Monday, went back to using full AGP. The problem was there's no level 2 PP equipment been supplied. They're also suffering a 20% abatement, and they are in absolute financial crisis at the moment. And there could even be as far as some industrial action going ahead in the near future. So my sympathy and thoughts lie with particularly Northern Ireland. As I said, the BDA have really stepped up the mark. Their website is often the first to go to for information. It's continually updated on a daily basis, and I recommend that to anybody. Even if you're not a member, there is the coronavirus webpage. Associates disputes are many, probably well over 400 that are being dealt with, and not just by members of the BDA. Currently, many have had problems with getting insurance through business interruption. This is going through the High Courts at the moment, and the BDA have put forward their case. There are big issues also with FD training and the cohorts of student coming through. All the chairs, the craft chairs, has sent a message to Dave Felix, chair of CopDent, and indeed spoken with him. Big problems, as understanding, with lack of experience, confidence, and indeed competencies at this stage. The Advancing Dental Care Programme has been slow and short in detail, and CopDent needs to improve their communications and decision-making process. I'm grateful to Ros McCullen for pushing and highlighting the mental problems undergoing during COVID. And of course, there is 24/7 counselling help through Health Assured, details again via the BDA. Again, particular reference to all the FAQs that have been put on there, not only during the lockdown phase and the return to work, but currently as well. And there are a lot of questions and forthcoming over the abatements and the side letters that the BDA has produced. And of course, this week it was announced that we have a 2.8% increase recommended fully by DDRB. And although we asked for more, this is what they've come up with. The government have agreed it, and it will be backdated till April the 1st. I'll make a statement. Private dentistry does matter, despite what many people think that we are only NHS centred. We are not. The vast majority of people will have some form of mixed practice involvement. We have made many remonstrations, both to Chancellor and MPs, and very little, unfortunately, has been forthcoming, despite our lobbying. Mick and Martin have met regularly with Joe Churchill, and Mick has given some excellent evidence to the Commons Health and Finance Committees. We will continue to work with all media, all outlets to push the case. And I would like to mention Eddie at this stage. Eddie Crouch has been immense, as well as others, but particularly Eddie. I think everybody in the country knows his face now. We still have a working relationship with BAPD, and we will still continue to talk with them. But however, we must absolutely appreciate that often we are fighting against a huge battle. I'll mention a couple of things with General Dental Council. We have lobbied. We are very disappointed that they've not reduced the ARF or indeed allowed it to be paid in instalments, particularly for the younger dentists and those really hard financially at the moment. The attitude to furlough those staff yet still pay them the extra 20%, I think, was inherently wrong, and we will continue to pursue that. We all know the difficulties with BAME and our colleagues, particularly our Sikh colleagues, and the difficulty in wearing masks and the necessity for HUDs. There is advice on our toolkit. There is advice on the NHS website, and we are doing further research into helping our colleagues that are suffering extreme difficulties at this moment in time. Fit testing has been a nightmare and still continues to cause problems. It's finally, as many have agreed to and Marion alluded to earlier on, there are now free fit testing training being done for up to 560 volunteers who are volunteered at no charge, and they are then will go on to train the practices they work in and indeed help other colleagues who are still struggling. The kits and solutions have been provided and the indemnity and honorary contracts are being sorted out, although there are still some issues with GDPR. We all know the issues with PPE. There are further guidances coming out. There's another urgent care guidance we've been asked to look at. And the availability and the modification of PHE guidance, some question was that to suit the availability, particularly now of FFP2s. And a lot of the 3M ones, the Aurora ones, are now not being made available by 3M. And many people are now resorting to reusable masks and respirators, provided they can get them. But of course, every time you change your mask, you have to be fit tested separately. And this again is a huge barrier moving forwards. Many are resorting to using reusable gowns, which can be machine washed up to 70 times. And nitrile gloves, whilst available at the moment, there is a distinct possibility that those are going to be difficult to find in the future. I do draw your attention to the BDA website, which has got a whole load of information there now. So the recent abatement agreements, that after long and hard negotiations, and again, thanks to Carol Rees and Matt Nelligan for understanding our position, it took an awful lot longer than it should have done due to the finance warriors and the people such as Ian Dodge and Simon Stevens, with agreements just being laid on their desk. The UDC practices will continue, but regionally they may be reduced in numbers as the increase in activity goes on within the practices. And currently we're running at about 95% plus face-to-face now. There are a few still doing AAAs only. The definition of patient care activity, which includes triaging and not just courses of treatment, I think is really important. Video calls, and we will again further clarify that with some more information coming out shortly. We have to make a declaration. We can't be doing AGP private activity and no NHS activity. It is out there and some people are abusing it, and we will have to make declarations, and assurances will be checked by regional teams. And of course we need to keep employing our staff, because we have been looked after very well, in my opinion, in the NHS, and we should not be abusing that either. So, work in progress. We have asked for clawback for 1920 to be spread over a period of time, and indeed the abatement repayments over several months, and ideally towards the end of the year. Orthodontics, although they're having the same abatement, I'm sorry, there are the same abatements, and there are some issues still to be outstanding and sorted out, such as closed down abatements, new contracts, extended treatment times because of those patients that were unable to be seen, where there were breakages or relapses. And we have another meeting on the 30th of July this month. So what's happening next? What's going to happen in Q3 and 4? What negotiations are going to take place? We certainly want to get rid of UDAs for good. What will happen beyond 2021? And how will we be measuring activity? And what else will happen? So to continue that, I'd like to introduce Sean, our Vice Chair, and then if there is time, we can certainly take any questions and answers. Thank you very much for listening.